Hey there, health enthusiasts. Welcome back. Today, we're diving into a topic that might sound a bit unusual, but is surprisingly common: foreign body ingestion. Before we jump in, make sure you hit that subscribe button and ring the notification bell so you never miss out on our fascinating medical content. Now, let's start. Though foreign body ingestion can happen to kids of any age, it most frequently occurs in kids with behavioral or developmental issues, and between the ages of 6 months and 3 years. Most swallowed foreign bodies pass harmlessly through the gastrointestinal tract. Foreign bodies that damage the GI tract, become lodged, or have associated toxicity must be identified and removed. Children with pre-existing abnormalities, example, tracheoesophageal fistula, stenosing lesions, previous surgery, are at an increased risk for complications. Older children with underlying psychiatric problems may intentionally ingest and require a mental health review. Gastrointestinal tract obstruction or impaction depends on the physical properties of the object, including its size, shape, and composition. Most complications of foreign body ingestion are due to esophageal impaction. The most common site of esophageal impaction is at the thoracic inlet, then mid-esophagus, and lower esophageal sphincter. Children with pre-existing esophageal abnormalities, example, repair of a tracheoesophageal fistula, are likely to have foreign body impaction at the site of the abnormality. Small objects, such as pills and smaller button batteries, may adhere to the slightly moist esophageal mucosa. Most foreign bodies pass harmlessly through the GI tract and are eliminated in the stool. Passing stomach objects cause fewer complications. Multiple magnet ingestions adhering tightly to each other through the gastrointestinal tract can lead to small bowel obstruction or necrosis. Zinc can interact with stomach acid leading to stomach ulceration. GI tract abnormalities. Previous surgery may cause abnormalities of peristalsis and obstruction of objects. Sometimes impacted foreign bodies cause local inflammation leading to pain, bleeding, scarring, and obstruction, or erode through the GI tract. When assessing the foreign body, needs to be vigilant about high-risk ones. High-risk FBs include: button batteries lodged in the esophagus need immediate removal, however, once they enter the stomach, they are less concerning. Large objects, greater than 6 cm long and or greater than 2 cm wide, may become entrapped at the pylorus. Superabsorbent polymers can cause impaction. Metal objects with a magnet or one magnet ingestion. Lead-based objects can cause acute systemic lead absorption. Multi-component objects may break apart and progress separately in the gastrointestinal tract. High-risk children include those with pre-existing gastrointestinal tract abnormalities such as congenital malformations, repaired or unrepaired. Eosinophilic esophagitis. Neuromuscular disease. It is rare for sharp objects to penetrate the mucosal wall of the GI tract, and these require no intervention if the child is otherwise well. Children with significant complications of foreign body ingestion may be initially asymptomatic. If evidence of coughing, choking, or respiratory distress, suspect inhalation. Esophageal foreign body symptoms include the following: dysphagia, reduced oral intake, weight loss, drooling, gagging, emesis/hematemesis, foreign body sensation, chest pain, sore throat, stridor, cough, unexplained fever, altered mental status. Stomach/lower GI tract foreign body symptoms include the following: abdominal distension/pain, vomiting, hematochezia, unexplained fever. Inspect the oropharynx for excessive drooling, edema, abrasions, ulcers, or lacerations. Physical findings may suggest complications of foreign body migration, such as tender abdomen on palpation, signs of peritonitis or obstruction, and rales. X-rays are unnecessary in an asymptomatic child with a reliable history and no significant past medical history. Imaging is required in suspected or known button batteries. Lateral view reveals a distinctive two-step border. Magnets, other high-risk radio-opaque objects, unknown objects, high-risk or unwell child. In smaller children, a single X-ray to include the neck, chest, and abdomen is often adequate. Most metallic objects will show up on X-ray except aluminum, variably detected. Further examination of the feces is not recommended. Repeat X-rays are not necessary unless for follow-up or if suspecting any remaining parts. The use of handheld metal detectors to identify the location of ingested metallic objects has also been shown to be useful. Endoscopy can also be used as a diagnostic and therapeutic method. Children benefit by being allowed to remain with their parents and being allowed to assume a position of comfort. For drooling, may need suction. Do not attempt to dislodge a foreign body from a spontaneously breathing patient by giving abdominal thrusts or syrup of ipecac. Impacted esophageal foreign bodies are removed by endoscopy. Pointed objects, thumbtack, should be removed as rapidly, and impacted button, disc, batteries can lead to local necrosis and should be emergently removed. Other methods. Foley catheter method. Here, the catheter is moved until the foreign body then inflated and gently withdrawn with it. Or it's dislodged and passed into the stomach. Need experienced personnel and healthy children with blunt object ingestion. Bouchonage method. Blunt esophageal foreign bodies are advanced into the stomach. Not be performed on children with known lower GI tract abnormalities. Observation and a repeat radiograph. Spontaneous passage. Blunt foreign bodies located at the LES often spontaneously pass within several hours. In the stomach or lower GI, most pass through. Long, wide, sharp, or impacted batteries need to be removed. The flow chart shows the steps to be taken when a child presents according to RCH Guidelines. A specialist referral may depend on the ingested object and local services. Objects impacted in the oropharynx require urgent ENT evaluation. Button batteries can erode mucosal surfaces, so need immediate removal. Ingestion of multiple magnets with or without metal requires early endoscopic removal. One magnet seen on an X-ray may still be high risk, as two may have been swallowed, which gives the appearance of one. Fish bones may lodge in the tonsils and require removal. If lodged in the lower esophagus, and can swallow saliva, successfully observe for 24 hours to ensure that it moves. If it does not pass, it will need to be removed. Larger objects in the stomach require gastroenterology or surgical opinion due to the increased risk of obstruction. Offering fizzy drinks to children with food bolus obstruction appears to be safe and may be effective. Consider discharge when the child looks well, is pain-free, has no respiratory distress, can eat and drink, has a reliable history and a low-risk ingestion. Discharge advice should be given, and the child and parents should be instructed to seek medical advice or return to ED if any of the following symptoms occur: breathing problems, abdominal pain, fever, vomiting, unable to tolerate food and drink, melena or hematemesis. Alright, folks, that wraps up our discussion on foreign body ingestion. If you found this video informative, don't forget to give it a thumbs up, share it with your friends and family, and subscribe to our channel for more engaging and educational content. Stay informed, stay safe, stay healthy.